Good morning from New York. Can you hear us?
Yeah, we can hear you loud and clear.
Okay, so I'm Dr. Kinney here, director of the Cath Lab,
Yeah.
who will be the operator, and then I'm assisted by Dr. Huda, who is our faculty here. I have Gaurav Kandelwal, who is trained and will be joining India as of January 1st, fully trained from us, and you will see him helping me doing the live case. I have Rajiv Samtani as a fellow, Pablo Asif as our technicians, Will, Ashley, our nurses, and I have Kiski, who will be our imaging faculty here from Sinai. Good morning to everybody, and we are going to, if you can introduce your faculty, we can start the case.
Yeah, Dr. Kinney, I am Dr. Ali Faisal. I am a cardiologist from Calicut, down up north in Kerala. I'll give my mic to my colleagues who are co-chairing with me or moderating with me.
Hello, Rustem Dautov. I'm a cardiologist from Prince Charles Hospital, Brisbane, Australia, looking towards interesting case. Thank you.
Hello, I am Dr. Praveen G. Pai from Amrita Hospital, Cochin.
I'm Dr. Saravanan from Coimbatore, Tamil Nadu.
And beautiful, and I'm here. Dr. Samin Sharma is supposed to be there, but in a different place.
Where are you, Dr.
Right
Sharma?
now. Yes, right now I'm in Mumbai.
Okay.
And will be just, and so I'm so happy that Dr. Kini could get all the staff, including the patient. This is, it's a Thanksgiving weekend, very big in India, in America, and they're able to gather the team and the patient for this lively, very interesting case. So I think if everybody is all ready, they will allow Dr. Kini to present the case and go forward.
Sure.
Okay, can we show the slides now? So, myself and Dr. Huda has nothing to disclose. So, if everybody can see the slides, this is an 87-year-old female who actually presented way back in October with angina class 3 and dyspnea, went to her private cardiologist, and then they did a stress echo which showed a multi-vessel, actually multiple wall motion abnormalities. So, though she is 87, not significant risk factors, controlled hypertension and hyperlipidemia, for which she was on medication with a metoprolol, a beta blocker, calcium blocker, as well as statin. So she presented because of class 3 symptoms, sent for angiogram, which was done on October 31st, which revealed calcified 3-vessel disease with the left main. You will see, I'll show you the angiogram also, significant calcific lesion in the RCA, bifurcating distal left main with the EF close to normal, 55%. Because of bifurcation calcium 3-vessel disease, her syntax at that was 30, and we all know with high syntax score, despite the age, we should always have a heart team discussion. So she did have a heart team discussion, but for obvious reasons, she underwent, both the surgeon, the family, and the cardiologist opted that she should undergo percutaneous revascularization. So she underwent a rota DES of the RCA. During that time, she actually developed a lot of slow flow, although the final results were very good. And subsequently, the residual syntax score was 22. So this is a right coronary artery. You will show that it is an anterior takeoff. Ostial 90% calcific lesion, again mid RC also 80-90% calcific lesion. This was the case that was done in October. So if you see here, we are trying to show that when you are doing ostial RCA rota, you need to use what is called as an extra support rota wire, and you are doing rota from outside, actually starting way back in the aorta from the guide, so that you can take care of the ostial lesion itself. So it was a 1.5 bar, and after that we did actually promise later 2 stents, and this is how the final results were after giving a lot of vasodilator therapy. Lot of slow flow was there with EKG changes. She actually required temporary pacer at that time.
And you can look at the how calcific left main is. See that left main and LAD is so calcific on other side.
Yeah, you can see that now it's angiographically tram track calcium of the left main, LAD, as well as the circ. So today we are planning IVUS guided PCI of the calcific left main. So going back to every case, we always go with is it a case appropriate or no. So despite her being elderly, because of her left main and 3 vessel disease, it becomes maybe appropriate. But then once you have heart team discussion, these cases do become appropriate. So the recent guidelines, what did they say? Assessment and predicting patient risk was very, very important, that when you are not sure what is the right thing to be done to a patient, heart team is very important. We did that in this case. Other things, what are the factors we need to consider is STS risk score in every patient. Though she is 87 with no other comorbidity, her STS was just about 2.5. And syntax we all calculate, and we all know her syntax was high. One thing that they have added in the current assessment is the assessment that was never considered in the STS score, which is presence of cirrhosis, frailty and malnutrition. So as they get older, malnutrition and frailty becomes very important. Sometimes your numbers may not look it, but then if they are frail and malnourished, the surgeons are not comfortable in taking these patients to the OR. So here we are today with a syntax, residual syntax of 22, STS of 2.5. So just a couple of things that we need to go over, that this patient, we are dealing with a complex left main bifurcation. Simple is very easy. You have distal left main lesion, or you have a distal left main with one vessel involvement only, and the other vessel is not involved. If left main disease, if you go to the complex side, however, you see distal left main and both the vessels are involved, as well as if it's not involved, it could be less than 50, but then the lesion length also could be longer than 10 millimeters. So this puts it into a complex bifurcation left main, and on top of that, severe calcification like we see in this case. So studies have shown that when you see the percentage of complex bifurcation left main is 32% or so. So when we see this kind of cases, several trials have shown that you should go with upfront 2-stent strategy, especially the DK Karash 5 has shown that. And now the question comes, this though our EF is just about 55 or so, with this complex intervention, do we need any support? So with the EF less than, with the EF that is just about okay, we could either use IABP or Impella. She showed slow flow and a lot of rotational atherectomy complication in the RCA. So we decided, because we are able to access, her access site was very good, that we will use just a simple Impella 2.5 in this case. And this is to say that, so she falls into category green, where EF is more than 40 complex PCI. So either IABP or Impella, but we have opted for Impella in this case. So having said that, I think we can, I'm going to show you the angiogram from today. If you can show the angiogram. So this is the right coronary artery. Looks very good. Yeah, the Impella. So her creatinine, when she first came, October was 0.8, today is 1.3. So we did not take LV picture. Echo was done about a month back, so there was no LV thrombus, so we just used that. So you can see circumflex disease there. Ostium is involved, and this is just to say, just on Sinai angiogram, tram track calcium. I don't think we need any kind of imaging to say, yes, this person needs some kind of modification. So this is where we are. So hazy distal left main, and there is a proximal LAD lesion also in this case.
And Anu, if you can just comment on it, IVUS versus OCT for the imaging, because I know the creatinine has gone up a little bit, and we'll ask the other panelists if they have any other thought on this particular case. And I'm sure that the use of Impella always comes questionable when you have low ejection fraction, but in this case could be appropriate with the knowing that right coronary became slow flow and so difficult, this heavily calcified vessel, you're working on it. If you develop slow flow, could be very catastrophic. But the point two, basically, emphasis once again, why Impella versus balloon pump. Second, is the imaging, OCT versus IVUS in this particular case.
Now, distal left main, but the left main is long enough. OCT can be done in this case. Because she's elderly and there was a bump in creatinine, that's the only reason we did not like OCT. But in every case, especially in defining calcium, understanding when to use what kind of device, I think OCT probably is better than IVUS. But if you want to just do left main and understand optimization of the stent and all that, IVUS is probably better for the left main itself. So it's all what the person is comfortable with. But we can see I think right now our plan is we will do rotational atherectomy first because of the significant lesion, and after that we can do the imaging to understand if the circumflex needs some kind of what kind of modification device, if that's okay with the panel.
Dr. Kinney, Dr. Sharma has already asked a question. So regarding the use of impella here, so it is a routine practice in a patient like this to electively put the impella, or if there is an evidence of any hemodynamic compromise?
Good. Excellent question. So in this particular case, yes, in any complex PCI, I think the complexity which was defined, I went through the slide slightly faster, because if your syntax is very high, calcium, low EF we are talking 25 to 40 or so, those kind of cases, yes, you do elective impella rather than wait for any complications to happen.
And again, the practice is to use impella rather than IABP.
Now, in this case, if there is no impella available and balloon pump is something that is available because the EF is near normal, nothing wrong in using IABP here.
Okay.
But
I think that's
if
very important.
plus the groin access. Remember, before we do impella, we have to make sure access should be okay, pre-close should be doable. So this person had a good groin access. So in that situation, yes, we decided let's go with impella just because it's a complex left main.
Yeah, so I think your decision for impella was a little more swayed because of what happened with the right coronary. That's very clarified, but what happened with the right coronary, and knowing that if the balloon pump may be okay, but if you have a choice and you can do it, even in the normal ejection fraction, as you know, based on the earlier trials, at present in United States for the complex CAD, even with patient with the ejection fraction more than 50, impella is reimbursable. I mean, it does not mean that you have to use it in every case, but key is that there are enough data to show that does cause less hemodynamic deterioration and acute complications.
So now we selected 1.75 bar here. So we actually, before you guys came live, we had wired it with the rotor wire. We have regular floppy rotor wire there. So we have it placed in the normal segment of the left main. I did my three things, which is here your knob, you go forward, backward. And then at the right.
Here?
You don't need extra support wire for this case, but for the right coronary artery we did use. So extra support wire maybe we'll use in like 10% of the cases, or mostly ostial lesion or distal lesions. Like if you have a distal RCA, PDA lesion, AV continuation and your burr has to reach there, that's the time you would use it. Here, since it is just proximal, we will not need it. So I did my 3 steps. Dinah?
Do you do IVUS up front in this case?
No, in this case, we did not select it just because angiographically we knew that was significant calcium, and left main was significant. So we thought let's do some kind of first round of a burr, and then we can go.
Is your strategy
Then we can do imaging.
Is your strategy up front provisional or two-stent?
Like I mentioned, since this is a complex left main and it's like 1-1-1, I think it's better we go with 2-stent strategy as shown by DK-5 trials, where they have shown that if you have complex bifurcation left main, better you go with the two-stent strategy upfront rather than go provisional and use bailout, because the use of bailout was over 60% in complex lesions when they did provisional. And when you use bailout is when you start having a lot of complication, and risk of stent thrombosis also is higher.
I would do probably a single stent in this case after rotor ablation. I was guided 87 years old, good left main to LAGF stent.
Yeah, I think what happened is in this particular case, we are not seeing a lesion in the ostial circ. Maybe one of the
Little
corners.
image, yeah.
Yeah, if there was a lesion, angiographic lesion in the ostial circ. So once you have 111, I know the EBC1 trial also showed that stepwise, if you want to go with a two-stent approach or go upfront two-stent approach, probably okay. So,
Dr. Kinney, you would have done a large number of rotas. So when you're doing a left main bifurcation, no? So is there any situation where you birth the left main to LAD and complication occur into the circumflex?
I mean, good question. So I think one of the reasons why we select rotational atherectomy, and I think for years together, and there are publications also that when you have bifurcation lesions and when you have a lot of calcium, the way the rotational atherectomy works, you see that? The whatever the diamond chips are only in the front, so they will burr the lesion. In that situation, the plaque shift or calcium or any kind of a shift that happens to the side branch should be lower. So we'll take a picture.
Okay.
Dr.
Rather than having any complication, yes.
Dr. Lee, sorry, the reason for temporary wire here?
No, only because she's elderly patient.
Okay.
Otherwise, left main and dominant RCA, you do not need it.
unless.
I think the rotational atherectomy has done its job, so we'll go with the side-by-side wire, and then we'll wire the circumflex also. We'll IVUS both, right? And then we can decide.
Sure.
If there is ostial circ, yes. That's a point well taken because she's elderly patient. If somebody wants to do provisional stenting, that's not a bad choice either. This is our workhorse wire. Okay, get the IVUS.
Yeah.
You want
So
to wire
key
the
is
circ now, right?
that IVUS is right now, will tell you a little more in terms of course, the effect of rotation atherectomy, but also try to see the ostial circ, because you're not given much dye because of high creatinine. And this is the kind of case.
I'm going to-
Yeah. In the end, you could do just one OCT run to see how the stents are fully opposed and so. And of course, IVUS require interpretation. OCT, with so much algorithms are there, they really tell you basically with their algorithm that your stent is fully opposed and so. But question here is whether there is an ostial circumflex involved. If ostial circumflex, just coming back to the point, our policy has been unless patient cannot take DAPT, we'll try to go with a two-stent approach. Whether it's a mini crush, that is our favored one. We rarely use a DK crush, but that is also is very good approach. We do not use culotte. I know a lot of people use culotte, but we never use a culotte by definition in our lab.
So I'm wiring the circ also now. So what I did was side-by-side wiring of the. Give me some dye there, yeah.
Then why don't you take one picture here also? Because it was not done before. Because of creatinine, maybe we can understand the ostial circ lesion a little better angiographically, and of course, you might do the imaging.
Okay. Let's just take a better picture. I'm trying to see if I can go caudal. Okay. Good?
Yeah.
Go. Okay,
Well, let's
get
get our comment from our panelists there, because to me, it's a long lesion of the circumflex also.
So you do you plan to birth the circumflex here with the or after the
Lot of
IVUS you take the
After IVUS, we can decide. Our plan was just to use a cutting balloon, and if it's really a lot of calcium, then maybe even IVL.
IVL? Okay.
Yeah. I would, remember this very angulated circ. I would say these kind of cases, we should keep away from rotational traction, because that's where the trouble can occur. One, it can create that gutter at the angle. Secondly, high chance of perforation. So in this case, if you cannot open the lesion, plaque modification by your high pressure cutting balloon or IVL, then only I'll resort to the rota in this particular case. So maybe our other panelists can say that how would they treat if it's a very calcific long lesion of the circumflex. As you
Okay,
can
start
see
the
that
IVUS there.
Okay, check the image.
IVUS is not crossing the lesion.
Can you show the IVUS?
Yeah, but see that at that level there's no disease.
Okay, IVUS start to back.
Angiographically there is, you
Yeah,
can
just
see
one
that.
quadrant chunk of calcium. So coming back. Yeah, here's also the one quadrant calcium. Yeah, so tight, block circ.
And that's
yeah.
osteal circ,
Yeah.
yeah.
Just one quadrant.
So there
Some
is osteal
branch.
circ disease and left
Yeah,
main
here's
disease.
tight, so tight. Come to the left main. Yeah, right. Stop.
Okay, good. So osteal circ give us a calcium, look like it was
Yeah,
180.
1 to 2 quadrant calcium.
Yeah, so we
Yeah,
could probably
I
try
checked the
cutting
type.
balloon, right?
Yeah. Not so much calcium in the circ.
Okay. Yeah,
And,
so we have a cutter balloon cutting, or trio is good,
Okay,
or
I will
you want to go
check.
3 to 5?
1
So
second.
trio.
The
I
EL.
think trio will be good.
Yeah. The EL to EL 3.2. Yeah, one size down, 3 always good. Safer.
Should we IVUS the LAD now?
Yeah. Of course.
Okay, I'm going to IVUS of the LAD.
The left main side is follow.
Left main is 4,
Yeah.
okay.
So let's ask our panelists also, now based on this
There is a
IVUS
question from the
information.
audience, Dr. Ajit.
Yeah.
Dr. Kinney, your IVUS was held back at that lesion in the circ beyond the ostium. Do you think there's some calcium there and you would run a rotablator once there before you get in? I'm not rotablating around the ostium of the circ, but just that lesion where the IVUS got stuck?
So that could be just the angle also, the way it was going, because you see it, if when we did the IVUS itself, we did not, there was, look at the lumen where the IVUS was stuck was large enough. That's one, and I think Dr. Sharma just mentioned also, it's angulated circ and try to avoid rotational atherectomy in the angulated area for the risk of one lot of wire bias. Now, you
Other
see that the
question is,
IVUS is not
maybe
going further, yeah.
You know,
Yes.
that IVUS versus OCT in this tough lesion, which is more, can be advanced better. So I think the other question of the Ajit was very important, that if there is truly a disease in that circumflex, and we know that
Okay, keep
calcium
going.
proximally was only 2 quadrant, but what if there is a circular calcium in that hazy looking napkin-like, ring-like lesion, and what we need to do a modification? I think it could be that maybe just do a balloon and see if it opens or not, and then you decide. By angiographically, it doesn't look that bad, but clearly the
No,
IVUS
angiographically, we plan to cover that.
yeah.
Okay.
You see, yeah, we are going to cover that, so we're going to go with the cutting balloon and take care of that.
Okay, I
But
start pull back.
LAD, start pulling back of the
The
LAD.
media ready. Yeah, so tight.
So
lesion.
now, this is where we are.
Yeah, come. I see some branch. Yeah, here's also
Now,
some.
mid to distal LAD, there is moderate
So
lesion
tight.
which we do not plan to intervene.
Here's so tight. Media ready. Yeah, 1 to 2 quadrant calcium. Yeah, diffuse disease. Not healthy lesion. I see some big branch. Yeah, I think. Oh, it's a left main.
That's left main.
More than 3 quadrant calcium.
Yeah.
Yeah.
So
And
I
some
didn't see
interruption.
good
Looks like there is
blood
some
exam.
cut in that calcium by the rotational atherectomy.
Sure, I saw also some revelation, so it means load worked. It didn't cross to the normal part.
Good.
Diffuse
So I think we'll go with the cutter to the circumflex first, and then we take care of the LAD.
But I would say that based on what we saw, yeah. But Ajit,
Cutting balloon.
why not go with a high pressure balloon first? To that second lesion, because second lesion may give a
If
trouble.
you use a cutting balloon now,
I guess the cutting balloon
Let's
has
try.
difficulty going there, and that circumflex looks very tight, that one.
Okay, we'll try.
Let's try. You know, I think it will be a good test. My prediction is cutting balloon with our Wolverine will not go to the second lesion, which we are concerned. And if not, then you try a high pressure. If a moderate, if it doesn't open, we know that if that did not work, IVL will not go,
Wolverine.
and we do a rotablation, maybe a smaller bar
This is
1.5.
high pressure 30 for LED. This is for LED.
LED?
Yeah.
No, circumflex. What
No.
size is this?
Cutter.
Yeah,
Cutter.
3O.
That is cutter.
Give me the cutting balloon. So we'll try the cutter to the circumflex, otherwise get us a 3 or 15 high, no, then get us a regular balloon, okay? 12. Have it ready? If the cutter does not go. So if you see the circumflex where the IVUS got stuck, we are trying to take care of that also and stent that area. Okay, let's see how this behaves. Can actually take care of the ostium, no?
Let me just go. Come on. 22.
Okay.
No.
Give us a regular balloon.
Not
then.
cutting balloon, yeah.
Yeah. Not with the high pressure, we'll go with the 12
So this
millimeter
actually-
balloon.
Yeah, this is a very important point that IVUS made us believe there's a 2-quadrant calcium and we'll be able to go through with the cutting balloon or so, scoring balloon, but clearly that with the angle, length, and of course, even those 2-quadrant, likely on the inside aspect of the left of the circumflex, didn't let the scoring or cutting balloon go. So now I think it's the right thing to go with to downgrade to our regular balloon or a high non-compliant balloon and then see how things are. Before it may boil down to, I know everybody asking, that do you do the rotationectomy? If this device does not go, then clearly it's a case that you use a small rotablation bar. Here, this balloon went very easy.
Now this is a compliant balloon, okay, we
Yeah.
didn't take once we know cutting did not go, we went with the compliant, go, dilate.
So what is the reason for using the compliant balloon, Dr. Kinney?
14.
So that you're down. The balloon itself, the material, the compliance is lower, but it will dilate. If it does not dilate now, so we have to create a channel track for the cutting balloon to go. So it is just the angle, I think. Look at that.
Yeah.
Look at that, almost 90-degree retroflex circumflex. That may be the reason, though the IVUS made that turn, you see it? So I'm going to do once more is try again here. Go up again. Down. So should we try cutting balloon again or we think we are good here?
No, cutting balloon. You had to use
You can
cutting
try
balloon.
one-
Okay, go up
one more
here.
time, no?
Yeah, okay, get the cutting balloon quick. And then we'll dilate the LED. But panel believes that we should do 2-stent strategy here.
I think,
You have to now.
yeah, majority believe.
Yeah, the reason also is having done all this to the circumflex and we do a provisional stent, if the circumflex then has, significant lesion or slow flow, anything happens, I think subsequently recovering the circumflex may be harder. So now we are trying cutting balloon.
So in a lesion like that, what is your usual pattern of stent usage? It's a decay crush?
I mean, we favor mini crush,
Okay.
just because the steps are fewer, but the world believes in decay crush.
And although a lot of people in Europe, they use still culotte.
Okay.
In EB1, there are a lot of cases but got the culotte in the 2-stent approach. The crush was very little.
You know what other thing I was thinking?
Start cutting from-
Let's dilate. No, let's dilate the left main. We did not dilate the left main. No, unnecessary. Okay, go. It's not. Go up here. He's saying dilate here. We did not dilate the left main to LED also.
14.
Okay, good. Down. So I'm going to rewrap it and then get into the left main.
What is the size of this balloon?
3O.
3012?
Yeah, no, this is a
306,
cutting balloon
Wolverine.
6.
Sorry, this is the cutting balloon. Yeah, sorry. Yeah, 306. And earlier balloon which you used was a 3015 compliant balloon.
12. Okay, now it went forward a little bit.
Dr.
Bob.
Ajit,
Dr. Kinney,
Little bit a millimeter, yes.
if this doesn't go, maybe
Down.
it's the angle, you're right. I think we should just get the guideliner on top of that balloon, old balloon, get it down and then pass the cutting balloon through that
Okay.
and then pull it back.
cross.
You go now.
Okay, good. It went in.
The same which we always
See, other, yeah.
Sorry.
So what we were trying, yeah, Dr. Sharma mentioned
No,
what you were
the
talking.
same, that once your nose of the balloon in the lesion, particularly this, whether it's any of those scoring balloons and so, it's okay to dilate there. Because that will make a room by creating some cracks in the circular calcium, and then it will advance. And this was the classical example, as you saw it. The gradual advancement, bring the flagstone there, Wolverine, and then gradually making a room. So that is okay. If it doesn't cross, you go further, start dilating. As long as the nose is there. If nose is not there, then you are in trouble. Then you have to go with the, just pointed out, going with the over the wire guideliner or Godzilla. But otherwise, you just go inch towards the plaque modification using the Wolverine in this particular case.
So this is a poor man's test we are doing. Yeah, good,
Yeah.
good. Go up here. Yeah, go up here. See, again, there was a little,
So deflating the cutting balloon, can it be this rapid or can it be a bit slower? Because there's different school of thought of deflating slowly.
Or, yeah, that's a good point. Or more important, when we started using cutting balloon in the beginning, the teaching was that when you second time inflate, you go slow. Because what happened is the balloon, the material in front of the blade, if you go rapidly, may cause a perforation. So, or perforation of the balloon, or rupture of the balloon basically. But whether you should go a little slow in terms of deflating is, I think it's
okay, down.
questionable. Whatever the
LED.
practice is, people want to do it slow, that's okay. But yes, what makes sense that your second or third inflation when you're doing after the first one, that you go a little slow, you give time for the balloon material which is wrapped now in front of the blades, time to really come off the blades. So slow inflation, but rapid deflation is, I would say, is a practice, matter of practice.
Okay.
But anyway, but Anu tried multiple times that the stent will go or not, tested by sending this the Wolverine few times, and it went in. And that lesion which was questionable where I did not cross. I'm sure there was a lesion, but was not a circular calcium, because we had got a very good result of this Wolverine that nicely expanded.
Dr. Sharma.
So now I'm going with a 325/30 balloon to the LED.
Dr. Sharma,
Yeah, this is
Deepak here. Despite having the maximum experience with rotablation in your center, it's good to know that you've given a lot of importance to safety. In this particular elderly lady, 83 years, you wanted to try to avoid doing a rotablation into that retroverted circumflex. It looks almost 90-degree angle, the circumflex ostium. Could you tell us what sort of angles would you try to,
33 will
you
be
have
too
a
long.
higher threshhold
Yeah.
for rotablation? When would you want to avoid rotablation? In what sort of angles would you avoid
14,
that?
16.
Yeah, so clearly if there is a retroflex, circumflex, which is just like this, there is a 110, 120 degree angle. If it is less than 70, I think it's okay. And I'm sure Ajit will say the same. Personal experience have been these horizontal 90, 110, 120.
We can come 1 or 2 millimeter into the left main
Yeah.
action.
110, 120, degree angle, their rotation atherectomy is troublesome. And the goal there now, I would say in this case,
Ready?
having done so many, I'll try to avoid rotational, but yes, that if there is no other device happens, then you have to resort to it. So I think opening the ostium a little bit and followed by, I would still try the IVL if the lesion does not expand before resorting to the rotational atherectomy. So I think the question is, should you avoid it? These kind of cases you want to avoid. In retroflex, circumflex, which is 90 degree, 110, 120 degree angles, if it is 70 or less, that is okay. But they are very tortuous, like in this particular case, may create a trouble. So idea there should be try to not to do a atherectomy, but just to say that if nothing else works, then you have to resort to rotation atherectomy with a small burr, and careful advancement of the burr will be the approach. Now, want to tell us what you are doing now?
So we used a 325 30 millimeter balloon. We dilated. So always do a Sinai to make sure that it's a fully expanded. So it looks like it's a fully expanded. We would not need any further lesion modification. If everybody agrees, we could go with the stent.
Dr. Kinney, why is such a long
No.
balloon? Usually you use this?
Yeah, so we carry 15, 20, 30. We know we are going to do a long stent. So instead of using a shorter balloon and use multiple times, we just like to use a 30 millimeter balloon. We are going to use a 33 millimeter stent here anyway. So you can finish, faster.
So if you were to do
Yes, so I think first,
Yeah.
So if you were to do rotablation in a retroverted circumflex, what precaution would you take? Would you downsize the burr size, or what exactly would you take care of? Like,
downsize the burr and use the floppy, rotafloppy. You cannot use the extra support, will clearly create the gutter. Downsize the burr with a usually 1.25 or maximum 1.5, and using the floppy, rotafloppy wire, and slow advancement. And you can see, if you're really having a significant deceleration, then you stop. You know that
right?
going further, going to
Oh,
create a
circumflex
bigger trouble.
Yeah.
So you want to
Get
basically
me a circumflex. Kiski? Length
Yeah,
of the circumflex.
it started 3.0 because we didn't cross the normal part of the digital LED. So maybe gentle pressure or 3 to 5.
3.0?
So those will be the steps. The smallest burr, 1.25, because you don't have to worry about
No,
the
circumflex.
You need a little
Length.
cut.
This is-
You just need a little cut into the
3.2
circumflex.
EL.
This is
Length.
12 balloon.
Yeah,
This is
we
12
did the
balloon.
last one.
Lamina.
I think
And
We didn't
24 is okay. This is 12 balloon.
23. So we plan to take a 3023 to the circumflex and 3033 Zions to the LED to left main, 325. And then I think left main we will post dilate with a 4.0.
Okay. Dr. Ajit.
Dr. Kinney, there is a lesion on that bend. Would you be leaving that alone or just?
Yeah, I think we mentioned that to begin with, that we will leave the mid to distal LED alone. Then it will become complicated.
3 for the sir.
What's the circumflex length you got on the imaging?
So from the start of the pullback to the bifurcation is 10, but we did not cross to the distal
I did
longitude.
not cross the lesion.
How much you got? 10?
Yeah, 10, but
No, this is
but I
23.
think
23.
23.
Yep.
I would say
No, we are going 23. Yeah. I'm doing eyeball, and then we have imaging, so we just compare. That's it. So we are going 23, 3023 to the circumflex. So when we are doing mini crush, that's we always do. You can show side by side mini crush video of the 3D bifurcate. So always go to the side branch. So here we may have issues knowing that. But we had done the multiple tests that a deflated cutting balloon did go. So I'm going to go to the caudal view, same view where we had seen. So go distal,
the Zions
that's where we park it.
Yep.
Yeah, and then
Thought it will be a
we
little
go-
difficult to advance, but the stent went because of the plaque modification which was done, step by approach, and particularly cutting balloon was quite helpful.
3 to
And of
5.
course, if there was an area,
stent,
yes,
LED
this
stent.
was the case where you will use IVL. If you think your stent balloon, your balloon did not expand, IVL to me will be safer, but some of them you cannot advance the IVL because of tortuosity, because of long lesion, then
Keep it
you have to
close.
resort at the last as the rotation atherectomy. And the orbital, some people say, what about orbital? I can tell you orbital cause a tortuous lesion.
compliant
Orbital
cardio
creates more trouble
If it-
than the rotation atherectomy. So orbital will not be the right choice in this
Huh?
particular. And orbital will be coming soon in India. In next, as I mentioned in my talk this morning, that the second quarter.
Okay, so here everybody can see it, the steps we are going to show of the mini crush. We will place the side branch first. It's playing there, the 3D video. So I'm going to pull the side branch of a millimeter into the left main. Good, right?
Yeah.
Some dye. Want to see Sinai?
Okay.
Just little dye. I'm going to pull back a little
Yes.
bit more, right?
Yeah.
Dr. Sharma, it's always a discussion about stenting
Okay,
left
okay.
main. Do you stent in the body or come to the osteum, even if there is no
Yeah,
much
so
disease?
that's a very good point.
Okay.
I know that
Go.
a lot of people will come up to the ostium,
Going up
but you know,
on the
ostium always can create a
Yes.
trouble for the future because
Go
then you have to
Yeah,
come
go
out.
up to the circle.
So we say
12.
that if there is no beaking of the
14.
left main, not even a 5-10% lesion, we try not to go to the ostium and just stop in the mid left
And
main.
down.
I know that a lot of people in Europe propagate that you should come up to the ostium, but remember ostium, to cover you have to then few millimeter out, which we all know the drawbacks of that particular technique. Then later on, you're engaging the guide difficult, maybe guide may disrupt the
Okay, now I have
ostium.
to pull this
So-
back. We have to take a cranial.
Yeah.
Okay,
I'll
they
go to
put the
cranial.
stent there, and now
Yeah, we
need
put the
to-
circumflex stent. We are adjusting the left main and we'll just go cranial to confirm the distal edge. So you can see the side-by-side animation there, okay? Yeah. Hold you, this is the, yeah, use some dye. I'm going to pull back a little bit because we have to have enough space for it to pot. Okay. Okay, good. Go up now.
Going up.
And this is a 3.5.
Low pressure.
33
Low
times.
pressure only. 12 only.
Yeah, we are going only, 10 atmosphere to deploy because proximally then we will post to 4 down. Give me a 408 high pressure balloon for the left main.
10 only.
Now this is just to
So-
our audience. It's a Giant Sky Point, which is not available here yet. Hopefully come soon. But basically the stent is the same. It is only the balloon delivery which has made it more deliverable. And as you saw that circumflex, the stent bend, I'm sure many stents will have trouble to make that bend even after the plaque preparation which was done.
So now we have a stent placed, you have to recross. The question always comes and there's always a debate. Do you recross first or do you recross after you're done the pot of the left main?
So would it be better to recross after doing a higher pressure dilatation at the circosteum with the appropriate size balloon, or is it better to cross before you dilate after?
Either way is okay. What I think we always try to say and we also promote in the app is you try to recross first. If you could recross easily, good. If you have issues, which means that the stent needs further optimization in the left main, then do that first. A lot of people will always argue by saying that it may go behind the stent strut in the left main. When you're recrossing, you may have issues. So a lot of, if they think that that's what the, so we'll recross.
We are not taking.
We'll take a picture, wait, I have to recross that. Give me some dye. The guide came out. Some dye.
Need to engage.
The wire came out?
Yeah, we have the wire has come out.
No, that's good.
Okay, now, there.
Inches.
I will try to recross the circumflex first. This is the LED there. We'll go to the caudal view and understand. First of all, let's take a picture to make sure our stent is good. Okay, ready?
Ready.
If you have trouble, then we have our 408 millimeter balloon ready to optimize the left main. Give me a new fielder wire maybe. Now some die, small branch. Despite lesion preparation, is still the circumflex looks hazy there. Okay, this wire is gone. So the same wire, we left it in the guide and then used to recross. But having trouble with the same wire, we're just using, the fielder was in the side branch. This is a polymer coated wire which is easier to gain access to the side branch.
Was a fielder wire, fielder FC?
Fielder, regular fielder. Okay, now get us a 3012 balloon to the side branch, right?
Yeah.
The same?
312 hybrid. Here the compliant. No?
We have the 40 for the left main to LED.
Yeah.
It's a new 3012. Where's the 40?
40 is here.
Oh, 8. Now usually left main, recrossing with the used balloon is okay compared to non-left main. Since we used a 30 stent, we are going with the 30 balloon. Any other question, technical questions?
What's the advantage of wiring the circumflex before optimizing port left main?
Before or after?
Yeah, before, like normally everybody does grid is like doing the port, you optimizing left main and then wire the circumflex. But wiring the circumflex first before dilating the left main.
I think it's just it's just I think operator preference. Like I mentioned, many people will say that here now even the balloon went easy.
Isn't it
Okay.
prudent to put a balloon
Down.
down the LED before trying to balloon the circumflex, especially since we've not done a
Yes, 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 yes.
This 40. Get a 3 to 5 high pressure.
Now we have a 40, 8 millimeter to the left main, and we'll use the same to do the kiss balloon.
So first you dilated the circ ostium and then sequentially dilating.
Yeah, no, but we are just doing the left main here, 40, because LED is just about 3 or so,
Yeah.
right? I'll go Sinai.
Okay.
I think they're okay. Okay, go. Can't see if they're right. Yeah, good,
14, 16.
good. Down. And I'm going to go inside and we can now do a kissing balloon. Now this technique also, there will be a lot of people discussing the same, that they would do pot, kiss and repot, but we are not a believer of a repot again.
And I think
Now,
but
don't
two
do
things.
that ostium.
No, you can remove the pacemaker you don't need and show the hemodynamics, because this is the most
6,
important
8.
point of the case, where Impala will help that prevent
8
any
only.
hemodynamic deterioration.
Down.
They should show the hemodynamics.
So
of this.
that's a kissing balloon we have done. So you can sequential, right? How are you went for the circle? 18,
18.
18, yeah, good.
So the kissing was done with the 4 and 3 balloon or?
Yes, yes,
18.
with the 4, we didn't go high. I mean, ideally you want to take another balloon, right, to the LED and do a kiss, but we avoiding that step. We just have a 4-0 and we have done sequential kissing. So we'll do imaging right now and show that we have fully optimized stent there. Okay, we can do the IVUS again. What do you think, IVUS, or you want?
OCT. No,
IVUS.
OCT more
OCT?
important. For the circumflex, you have to go further down with a balloon in the circ. Remember, there was still a dent in the stent. Circumflex balloon, you have to go a little further in.
Yeah, there was a dent in the mid portion of the stent in the circumflex.
Yeah, exactly. That need to be opened better. And I think that was just part of the plaque prolapse within to the stent strut. You need to just optimize there.
Keep another balloon ready in case.
Or you can do a little anchor with the LED balloon little further down.
Now I want to take probably a shorter balloon. It's a 4.0 in the
Same balloon.
LED,
take,
so
The anchor will be okay
Go
with a
here.
moderate pressure. Yeah,
Go.
moderate pressure will be okay.
10.
8 or 10
let's
here.
see.
Yeah.
We just not change the balloon.
Despite a 12 millimeter balloon. Huh?
Just not change a balloon, that will be easier.
This is exactly where
Go.
the I was also getting stuck there. Okay, go.
But go up here first. Yeah.
No, I
You
don't
can
know.
dilate there
Deflate.
initially.
12, 14, 16.
Okay. Down.
And hemodynamically patient doing fine when you have double inflation, pressure does go to about 90.
Sir,
Very slow deflation.
Need to dilute.
get a
I
308
think I will take a 8 millimeter balloon if you really
308,
want to do it.
308. Yeah, and see.
Yeah, because I think the impella helps for keeping it long. Dr. Sharma, what will be a recommended time for
you can,
inflating the balloon?
You can come and ask.
Yeah, no,
Anchoring balloon.
we take out at the end of the procedure. Our 99.
No. No, they're asking a anchoring balloon, how long do you keep it?
No, just.
So you keep it as long as you are able to cross, that's it, and then immediately deflate.
No, not the anchoring balloon. Usual balloon inflation, what is the time? That is what was asked.
Ah.
Oh, sorry, got it
I
wrong.
know that there are some data in the literature that prolonged balloon inflation gives you better stent expansion, or if you do a balloon only, gives you better results. But I think it's as long as you are inflated and the dial on your
Go.
inflation dial that pressure is maintained, it's not going down. So that's
18.
okay. Now, many other, once you are using a drug coated balloon or any other, technique, probably and particularly the absorbable stents, you need to be a longer, but otherwise just as long as
14,
the
16.
balloon inflated
Down.
and it remain inflated for a few seconds. So our practice has been just 10-15 seconds only, and particularly with the
Okay,
left
so please
main,
again.
we want to have a shorter balloon inflation possible.
Okay, go.
So the hemodynamic issues.
Just a
Four,
question, are you
8.
working on field the wire or you swap this in
Yeah.
circumflex?
Down.
Down. You're still on the fielder, same fielder wire, yeah. For the side branch, we always like to use the polymer jacketed wires, fielder, OCT is ready, okay. So we'll
And
take
fielder
all the
FC.
wires out.
So the question was, should you use a fielder FC or FT? Problem with them is they're easy to go to the side branch, but they don't provide the support. And that is why the usual for the side branch, and that is part of the guide wire app which Dr. Keeney has created, is that we try to go with a regular fielder because it gives the moderate support. Fielder FC and those can go, but then they provide a very little support for advancing the devices. So you want to just show the picture now, Anu, so that we can see the circle?
No, I think let's avoid, because we're going to give more dye here, so let's do OCT. If it looks good, then we do a final picture.
So just for everybody, look at the blood pressure of 130.
Yeah.
Anytime they did a balloon dilatation of the left main and so used to become 80. So that is one of the corollary advantage of these assist devices that prevent hemodynamic deterioration and allow you to do your procedure at ease without the patient or the doctor sweating.
Okay. So you use an IVUS pre-procedure. So is it a practice there to use an OCT or an IVUS post-procedure?
So I would
Ideally, you should use IVUS for post-procedure also, but
there was a demand.
Dr. Sharma likes OCT as per demand, he's saying.
Okay.
just to see. But yeah, coming, I think we should go to AP cranial view. But yeah, the usual, I mean, you want to use the same device. But in this particular case, but I think OCT telling us good stent expansion with those red color dots and so, very reassuring that you have done a good job and there is no dissection.
No, why are we going here? Circumflex, we are in the circ, right? Go down.
Yeah. You want,
Don't listen to him.
you're on circumflex. Want to go on LED?
Okay, let's see.
And remember, the pacemaker is coming in between. We can remove, somebody can remove the pacemaker.
Okay. Goodbye. I was crossed, and let's see, will the OCT make a turn into the circumflex?
Although now it's a different. Now has a cutting balloon and stent.
No, still not making it. See there? And I don't think we should try to push or do anything we could have.
Just do it, show it in the LED only then.
Yeah. Okay, I'm trying to see.
Dr. Sharma, about the balloon inflation time, because we all find it's very super fast, inflation and deflation, because there is quite a few people shown in benchmark saying that slow inflation and complex lesion, leaving it a bit longer time, definitely does break a bit more and gives a better expansion. That's what the general consensus most people feel.
Very good point. So I'll tell you a few data. One is that if you are trying to do only balloon inflation results, so there, you know, we did the trials back in 90s when stent was just coming up. There one was that we used to crack the balloon, go to 16 atmosphere, and then go down to half, to 8, and leave it for 90 seconds. And many cases, which is now my fellows and everybody knows, I do it when I'm not putting a stent. And many times it gives a great angiography result. Second, people used to go oscillation. You go to 16 and you do a little down, 12, then 16. We did a trial called CRACK, C-R-A-C-K, late 90s. So it didn't show much difference. So there are some data of that kind. But yes, as you mentioned, leaving a balloon for longer period of time, 30 to 90 seconds, has correlated with better angiographic result and stent expansion. I saw only the abstract about 6-7 years ago. I don't remember of a paper published, but some data are the longer in balloon inflation. But we know that what we do, we always do 2 inflations. So maybe our short rapid inflation deflation, but 2 inflations, hoping the second inflation will have a more circular, the expansion of the stent may counteract this effect of the long balloon inflation. So yes, if you want to get a good results, the enough data are that 60-90 second may be better than doing a shorter 5-10 second inflation which we routinely do. So I don't know what your practice is. Maybe you can comment and maybe other panelists also.
We can do from here.
Yeah.
Thank you. I mean, I don't leave at 30-40 seconds, but at least I leave for 20 seconds at least. But
okay. I would say that that's fine. We will do 10 times 2. We always inflate the balloon 2 times with a stent, hoping that there was actually, one time some people used to say, I had never seen any the paper on that, that basically second inflation really gives you more circular expansion. So we'll do 10 seconds times 2.
thank you.
So you know.
Ready?
Yeah.
Okay, we're ready for the OCT.
The lady. Yeah.
Left meant ready because did not go to SIR. IVAS didn't go, OCT did not go.
Yeah, perfect image. I will check.
Now you show us where the distal left main is, where the stent has covered, the circumflex stent, okay?
And then, yeah, nice. Okay, I will show you the detail.
Okay, for the first glance, there's not a single red dot.
Yeah, true.
You see that? Show
And
that as stent.
now I see
First
that this
stent.
is the proximal left main, the perfect expansion, normal opposition, no dissection, well expanded. And I come to the bifurcation. Now I see the circ from the 5 o'clock. Here's also expanded. This
Do you see the crushed stent?
Yeah, this is osteal lady. The lumen area is 6.4, we'll expand it. And go to the distal, yeah. Through the stent, we'll expand it. Then they check, okay, so this is the distal edge of the stent. Some small dissection, but or it's on the
I think it's on the lesion.
yeah, true. So it's not a dissection.
Yeah, it's on the lesion. Okay, go back to the osteum. Now, overall, show the full stent.
Okay.
Bird's eye view.
Yep.
Okay, see, not a single red dot, so we
all
know it's
white
fully
dot.
yeah.
So
Yeah.
this is the like clash stent part.
Oh my God is the expression. Beautiful.
Beautiful.
Okay, now show me the distal edge of the, sorry, no, not the distal edge, distal left main
Sure.
at the osteal circ.
Yeah, so this is the bifurcation part. I see the circ from the 5 o'clock.
You can't see the crushed stent.
1 second.
No, they have it.
You can see
You can see it there.
Yeah.
Yeah.
Maybe around here, like some clash one. Not super protruding, but looks like cover the
Okay. That's good. And then you're saying the left main is well opposed.
yeah, well opposed, well expanded.
Okay,
And then-
give us a quick CSA. We're good.
Okay, left main CSA is 1 second. Automatically like 7.3. Oh, 1 second. Okay, I checked the detail. Yeah, I can collect. Yeah, 8.6 is the tightest.
Yeah.
Okay.
I think it's a good result.
Okay, acceptable.
Yeah.
Yeah.
The distal edge, you can
So I
just
think-
make sure the distal edge is okay.
So
Yeah.
I think the inaugural, we have some more time, a few minutes only, because there's an inaugural function going to happen here. A minister is going to come. So
Look, it's on the plug.
Change the settings.
can
This
go
side.
Can you just show the last picture?
Yeah, we have some more time.
And we are done with that. Yeah.
Yeah, we are going to do a last picture
Yeah,
and
sure.
then
We
you
have
can
time.
start your inaugural function. Yes.
We have time.
Any other question meanwhile to any one of us? We are giving some vasodilator. The final picture always with vasodilator, little nitro. Okay, ready? Good.
Yeah, ready.
You will remove the
Start weaning the
yeah.
impeller.
So that's what question I had. You immediately stop the impeller or not after the procedure?
Immediately.
Yes, we are going to wean it. It will take about 10 minutes to wean the impeller. We will explant the impeller here in the lab. We will close it, under fluoroscopy guided. We already have pre-close. We'll post-close it, and then patient will go to the floor or ICU.
I think the angiogram
Yeah.
looks excellent. Good result. Very good.
And I would say that a lot of technical points in this particular
Yeah,
case.
a lot of
which were
discussions,
Step by
technical
step,
points.
yes.
The discussion on supporting the support in high-risk cases. So from my side, Dr. Kinney, Dr. Sharma, thank you very much, and our team at New York for coming at such an early hour and doing the case. So I'll give my
I just have to show you the contrast used was 140 with the fluoro time of 31 minutes and air karma radiation just about 10. So anything about 2 is reportable, but this yeah.
thank you.
Yeah, thank you.
And we
for the-
thank
you.
We also
Thanks
thank
from Cochin.
Dr. Anil Kumar and the
Anil.
CHIP Summit faculty and the audience to be there and I'm able to show this masterful case by Dr. Keeney and the team from Mount
Thank you,
Sinai.
sir. Thank you. I
everyone.
appreciate Dr. Kinney. Thank you very much for coming up on this Thanksgiving Day. It's made a huge difference and we still have a full house here. I appreciate your case and the dedication you showed in showing. Thank you, Dr. Samin, for holding on from Bombay also. Thank you very much.